Are you a healthcare professional looking for a trusted concussion resource? Then you've come to the right place. From her New York City studios, welcome to Concussion Corner with your host, Dr. Jessica Schwartz.
Welcome to the Concussion Corner podcast. My name is Dr. Jessica Schwartz, and I'm thrilled to have our guest on today. Traumatic brain injuries and concussions are never clean and clear-cut. In fact, they're messy, often presenting with concomitant injuries that have often been missed or misdiagnosed. A direct quote taken from her 2002 paper with Ken Ciuffreda, clear and single binocular vision is required to participate actively in physical therapy, vestibular therapy, cognitive therapy, speech therapy, and occupational therapy. Did you know that 2/3 of our brain's pathways are devoted to vision? That's a lot of devoted neural real estate to a beautiful complex system that make up the human form. As a physical therapist, I didn't realize the subtle and not so subtle aspects of vision's role in function and performance until my own concussion. My respect for the neuro-optometrist, for return to life, return to function, and performance is forever ingrained in my clinical practice. This brings me to our introduction of whom I believe to be one of the top 5 neuro-optometrists in the world who treat traumatic brain injury, acquired brain injury, and concussion. Meet Dr. Neera Kapoor. Dr. Kapoor graduated in 1989 from the University of Toronto with a Bachelor of Science degree in Biochemistry, after which she moved to New York City for advanced graduate studies. She completed a Master's of Vision Science, Doctor of Optometry, and Residency in Vision Therapy and Rehabilitation at SUNY College of Optometry in the mid-90s. Dr. Kapoor remained on faculty at SUNY College of Optometry, where she eventually attained the rank of Associate Clinical Professor by 2003, and then served as Chief of Vision Rehabilitation Services from June 2010 through early July 2015. In January 2016, Dr. Kapoor transitioned to NYU-School of Medicine, where she currently holds rank of Clinical Associate Professor of Rehabilitation Medicine and is involved in clinical research. She is a neuro-optometrist at NYU-Langone Health RUSK Institute of Rehabilitation Medicine, providing clinical care for outpatient and inpatients. Dr. Kapoor has co-authored over 30 peer-reviewed articles, 10 textbook chapters, and 25 poster presentations, as well as having presented over 100 lectures regionally, nationally, and internationally regarding vision and acquired brain injury. In the spring of 2018, Dr. Kapoor was honored with the A.M. Scuffington Award, which is presented to the XVIII Fellow who has made outstanding contributions to the optometric literature in the areas of vision therapy and vision development. Dr. Kapoor, welcome to the Concussion Corner podcast.
Thank you so much, Dr. Schwartz. I hardly believe you were talking about me there.
I know, we all have to kind of settle in and get past our what do you call it? The imposter syndrome that we all live by and live with.
So true, so true. But thank you so much for those kind words and that wonderful, warm introduction.
Of course. And just so our listeners know, so Neera and myself are actually both in New York City, both in our home offices today, doing this recording. So if you do hear any background noises, it's just real life New York City. So we don't apologize, but we're just letting you know.
Absolutely. Absolutely.
All right. So Neera, I start off every podcast essentially with, someone starting with very Simon Sinek-esque, starting with their why. So essentially why you got into optometry and how you ended up in neuro-optometry.
Well, it's a long story, but the short version is it all stems from my parents and my mentors. My mother originally had suggested when I was looking at what to do when I finish undergraduate studies, what to do. She said, well, you've always wanted to be in healthcare and you love optics and physics, so go into optometry. So being a good, dutiful daughter, I listened, and I actually quite fell in love with optometry early in my school days. Mm-hmm. And while I was in optometry school, courtesy of my dad, I became more interested in vision therapy. And it's not that Dad's an optometrist. Dad is actually a retired, brilliant criminal defense attorney. And when I was 12 or 13, I was given a prescription for glasses for farsightedness, hyperopia, And when my dad saw my glasses, he looked at them carefully and then he looked at me and he said, "You and I need to go running and we're going to do exercises every morning, eye exercises, for the next couple of months. And you may not need these glasses anymore." So, of course, the running was to get me into shape, but the eye exercises were really addressing the ability to change focus, which is called accommodation. And indeed, after 2 months of working on accommodation and performing smooth pursuit with deep breathing, as well as all of that running, turned out I actually did not need to wear glasses for about 15 years. It worked. Who knew?
Awesome. All
And
right.
then I did a residency in vision therapy, and that's when my mentors, Doctors Ken Kafrida, Erwin Suchoff, and Barry Tannen, really got me into vision and acquired brain injury, and I fell in love with it. I've never looked back.
That's a wonderful, wonderful story to connect to. And, I think we often don't connect to these gurus like yourself, really where your passions, stem from. And, the mission of the Concussion Corner podcast is really to fill those cognitive blind spots in the healthcare community, shifting providers' anchoring biases towards, whether, objective measures, utilizing comprehensive and targeted physical exams, facilitating these thoughtful interdisciplinary conversations. And, your work really has, you've been way ahead of the game in doing this for decades. So it really was wonderful to kind of reconnect to your work while I was preparing for this podcast. So I'm really excited for the listener to lean in and learn from you.
Thank you so much for that. We certainly, I owe a lot of the forward thinking of the work that I've been involved with over the past 2 decades. I owe it to an immense degree to my mentors, Doctors Kafrida, Tannen, and Suchoff. They always pushed me and said, "Well, why are you noticing this in clinic?" And I would tell them something, and then they would say, "Great, how can we study that now?" And then we'd come up with a study together. And that's how we started publishing data over the years since the early 2000s.
Awesome. So, let's kind of, fill in these cognitive blind spots for our listeners, which are primarily healthcare practitioners. And
Sure.
really, kind of to start off with really what is a neuro-optometrist and really what makes you different between the, optometrist, taking acuity measures in a local eye shop to what you're doing in your clinic and your research.
Well, I think one of the things is if you're talking about a neuro-optometrist or a rehabilitation optometrist, you're talking about somebody who has had experience in dealing with patients who have vision problems, in patients with neurological compromise, and they know how to basically translate ophthalmologic data and neuro-ophthalmologic data for other therapists, such as those in speech and language, neuropsychology, vestibular therapy, physical therapy, and OT, occupational therapy. And not only do they translate that into something that's functionally applicable, but they can also provide tools and compensatory approaches or reasons why patients are having difficulty in each of those different therapies. And further, the second role, aside from translation for a neuro-optometrist, is to provide actual therapeutic interventions, either working in conjunction with occupational therapy or physical therapy, or independently providing therapy for patients who have either double vision issues, blurred vision issues, visual vestibular symptoms, reading-related issues, visual field defects, and light sensitivity. All of those aspects become impacted following concussion, and we certainly try to work with our other colleagues to try to better the care and function for our patients.
Indeed. And in terms of your education, Neera, what is your educational differences, with the basic optometrist that may be working at a local, mom and pop or like a lens crafters or Pearl Vision, and then your education, as well as a neuro-optometrist?
Well, I'll tell you that certainly being residency trained is important because it shows that you've taken that advanced degree to learn more about vision therapy and rehabilitation. So even if an optometrist does not have residency, they're not residency trained in neuro-optometry per se, they should at least be residency trained in either vision therapy and rehabilitation or have a fellowship in the College of Optometrists in Vision and Development, or a fellowship and Neuro-Optometric Rehabilitation Association. Those are ways that you can know the optometrist with whom you're working and with whom you're providing care or receiving care really knows and is familiar with how to care for you.
Indeed, 100% agree there. And just for our listeners, you may hear us use those terms like COVD or NORA. And can you just let the listener know one more time what those things mean?
Absolutely. COVD refers to the College of Optometrists and Vision Development, and that has been an organization for years dealing with people who have problems with binocular vision, eye tracking, double vision issues, focusing issues. And all of these originally, when COVD was formed, they were geared towards people who have learning problems. But now, over the past 2 decades, it's also been including those with acquired neurologic issues like concussion and traumatic brain injury. Neuro-Optometric Rehabilitation Association, or NORA, was specifically founded, I think probably 2 or 3 decades ago, specifically for vision issues following neurological compromise. So going to either site to find a provider will help you well in knowing that the person is trained and certified in dealing with these kinds of patients.
And we'll have all of those show links for everybody in the show notes and things like that. So not to worry. So not everyone needs to take notes while they're listening in. Now, the term neuro-optometrist and behavioral optometrist, are those synonymous with each other?
That's an excellent question, Jessica. They're not necessarily synonymous, and that's why when I'm referring a patient to the COVD website to try to find a practitioner closer to where they live, because sometimes patients will come to me from a long distance for a consultation, but I'm not going to be able to work with them on a weekly basis. I always tell them, now here are a list of names. You're going to need to call these people at COVD to see if they've had experience in brain injury or not.
And that's the universal question for everybody, right? No matter
correct.
what. And I talk about that all the time, either on the podcast or when I'm teaching, is that we really have this thing called degree bias. So it's not so much the degree after someone's name, those letters, that alphabet soup. It's really, do they have experience in brain injury? And that's a very important question to ask.
It's a key question because behavioral optometrists may have more of their expertise in dealing with children. Okay. Some may have more of an expertise in dealing with autism, and others may have more of an expertise in dealing with acquired brain injury and traumatic brain injury and concussion. So I always tell them, you need, just like when you're calling up a neurologist to find out what their expertise is, you have to do the same kind of thing in this case too. For the NORA website, Neuro-Optometric Rehabilitation Association, when you go to that website, all of the practitioners deal with acquired brain injury, traumatic brain injury, concussion, and stroke. So there is much less of an issue regarding experience.
Indeed, that's good to know, and really good for when providers are out there trying to form their interdisciplinary team for their concussion clinics that may be popping up all over.
Correct.
So in terms of really, why is vision so important? I drop these 2 stats. In most podcasts, we talk about 2/3 of the brain's pathways are devoted to vision. That's a lot of neural real estate devoted to our eyes, and about 70%. Similar numbers. Of our sensory environment really comes through our eyes in terms of how we function. So, what is vision and why is it so much more than 20/20?
That's really key to know. It is more than 20/20, Jessica. And you're right. There's a very large amount of cortical real estate that's dedicated to visual processing. And to me, it all starts with ensuring that the person has the ability to achieve 20/20 in each eye. The next step is, do they have the appropriate integrity of the structures of their eyes? Now, those two particular aspects are addressed by most eye care practitioners that any of us see. You go to the eye doctor, what's the lowest line you can see on the chart? That's great. Let's look at the other eye. It's pretty straightforward. Then they say, now follow my finger. Super, great. Look at this light. They check your pupils. They'll look at the front structure of your eyes. They'll check the pressure in your eyes. They dilate your pupils to make sure that the structure, the ocular integrity, is appropriate. And most of the time with concussion, not always, but most of the time, these areas are not impacted. And the person actually has 20/20, and the structures of the eyes are great. But the problem is they're feeling that they're having difficulty using their eyes. And that's why I tell people to think about how your eyes function. And that's really where neuro-optometry, behavioral optometry, rehabilitation of optometry comes into play. We can use our eyes either independently or together to change in terms of clarity of focus, okay? That's accommodation. And that's really important to be able to be able to look from far away to up close and back again. In particular, for those of us who are under the age of 40, that's the norm. We should be able to do that. Once we're over 40, we start to need reading glasses. Fine. Now, let's say you are able to make those changes in focus. Terrific. The next part is, can you move your eyes independently and together, either for a smooth pursuit to follow an externally moving target, right? Either horizontally, vertically, diagonally, or rotationally. And that is often impacted in our patients with concussion. They have difficulty moving their eyes upward. They feel that it makes them very dizzy or have eye strain and nausea. Sometimes it's almost painful for them, okay? So that's important. The other thing is it's difficult sometimes to keep your eyes fixed on a target, and that's called fixation. And yes, that is an actual eye movement. It's important to be able to keep your eyes steady on a stationary target. That's how we process information. Think about the number of times that you look at a photograph, right? Or you read something. When you look at the word, you keep your eyes fixed on the word, you take in the information, then your eyes jump to the next word. As your eyes are jumping, you're not taking in information. That's just movement, right? You process the information when you fixate. But let's say your eyes cannot stay fixed on a stationary target. That's problematic. Then you can't process information. And this is an issue for our patients with concussion as well. We talked about jumping from one target to the next. That's called a saccade. Okay? Now, fixations and saccades, we use those all the time when we read or when we're scanning an environment that we're walking through. And if that saccade, that jump, is inaccurate, then either we have to recorrect, which takes effort, okay, and can make us, again, dizzy, nauseous, uncomfortable, or it can just make us more tired. And after concussion, anybody with concussion knows that neural fatigue is so common. So anything you can do to reserve that neural energy is a favorable thing. The last aspect really is vergence eye movements. Those kinds of eye movements, Jessica, are when you track targets in depth. When I move my eyes far away, both of my eyes far away to look at a distant target, my eyes are more parallel or divergent. And then when I bring them closer together to look at a relatively closer object, that's called convergence. All day long, we're converging, diverging as we're navigating through our environments, as we're reading on a computer for sustained convergence. Okay? These types of things are what make vision so much more than just 20/20. And this is just looking at eye movements. I haven't even gotten to visual spatial issues, which is for another podcast.
Right, exactly. Part 2 or 3 for us.
That's right. But these are the more critical things that we need just to make it through a day.
Right. And just to comment there, you were talking about, structure and ocular integrity often being normal in most concussion patients. And just for our listeners to connect to, our patients actually feel helpless or hopeless, or maybe even use the word crazy. They've been to the quote unquote eye doctor, they've been to the quote unquote emergency room or department, as all of our emergency folks call it now these days. They're much more than a room these days. I get yelled at all the time by our emergency medicine colleagues.
Me too.
They've been to the quote unquote doctor, whoever that may be, and they're told that their scans are clean and everything looks good, but they feel like hell. And this is why it's so important to really have a neuro-optometrist like yourself on an interdisciplinary team, an interdisciplinary rehabilitative team, I should say. 2017, our listeners are probably nauseous of me here, saying this over and over again, but, ad nauseum. But 2017 was the first formal didactic year that internationally we agreed that this concussive injury is a rehabilitative injury. And this is an all hands on deck injury, from physio to OT to speech, psych, neuro-optometry, and the list goes on, and including our psychology friends and colleagues. So we have to make sure that when we're, leaning in and listening to Dr. Kapoor here, guys, is that you're really paying attention that vision is so much more than 20/20. And then if your patient says they went to the eye doctor, well, you really have to ask the questions and become much more specific in your subjective histories of, well, hey, what kind of optometrist was this? Was this a CVIII trained neuro-optometrist or a behavioral optometrist that's out there? And really get a little bit more specific in, your patient history taking, because it really can make the difference in their overall outcomes.
I would agree very much. And I also do want to specify that even though often with concussion, structural integrity is not impaired, that does not really sort of preclude a patient from going to see their regular ophthalmologist, their regular eye doctor. I tell patients all the time, I'm very much a structure to function kind of girl. It's important to make sure that structural integrity is there. And these eye doctors, they're my colleagues, they're my friends, and they're brilliant, and they know what they're doing, and they're not wrong when they say everything that they have assessed looks good, because everything that they assessed did look good and is good. But it's these other particular areas that neuro-optometry, behavioral optometry, rehabilitative optometry assesses that may be impacted, which is why it's important to have it assessed. If you've got a patient that's still visually symptomatic and they went to their eye doctor and the eye doctor says everything's great.
Yeah, and it's such a common thing that I see, and I'm sure that you see as well, with your concussion patients. We have folks reaching out to us and contacting us from all over the world, and that's not uncommon in this area because this is such a specialized area of concussion rehabilitation, really internationally. The same conversation is happening all over the world. With regard to that same theme, the Concussion Corner podcast and everything that I do and believe in really is about building others up, but we can also learn from our mistakes as well. So what are some common themes that you've seen in your, career over the last 2 decades? And personally, I think the last 5 years of concussion conversations have significantly shifted and changed in terms of the rehabilitative components, based off a lot of what your work has been out of NYU and the SUNY Optometry, some of the work and publications out of UPMC, and then we have our concussion and sport groups, which get a ton of press, I should say, and attention. What are you seeing? As twofold question. One, in common themes, maybe 3 to 4 that you can think of clinicians that have essentially missed the boat. They missed, either misdiagnosed something or omitted that from their evaluation and completely missed the visual components. What are some common themes you're seeing there? And then also, let's just leave that there. Let's go with that, and then we'll keep going from there. And we're about, we have about 10 minutes left, so I think this will be a good place to wrap things up.
Sounds good. Regarding common themes in terms of providers who either were unaware of visual components of brain injury or may have missed certain things, I think a lot of it comes from people's or providers' particular experiences with vision practitioners in their part of the country or the world. And if they don't have a provider that's trained in this, they might think, well, I don't know how serious this is. Like, how real are these issues?
Mm-hmm.
And sometimes I find that when I can speak for myself only, when I speak with providers that didn't normally think of neuro-optometry, when I talk to them and I talk about specific conditions that I can do anything about, because there's not that much I can do a lot about. I've only got 6 or 7 things. I can only deal with blur, eye strain double vision, reading-related problems, visual vestibular symptoms, light sensitivity, and visual spatial processing. That's pretty much all I've got. That's it.
Which is a lot.
But when I go through those and I talk to providers about how patients may present, I say, if your patients present with constant or intermittent versions of any of those symptoms, please read my current treatment options paper from 2002. It outlines what I can do for them, what any neuro-optometrist can and will do for them. Please look at the 2013, 2014, 2015 papers by Thiagarajan and Dr. Kafrida, because those papers show you objective eye movement recording results, pre and post intervention. And they stayed up to 3 months post intervention. That's powerful information.
Those are big numbers.
That's really, really powerful. Even if it's a small sample size, when it stays, that's powerful. Providers who didn't normally think about neuro-optometry, when they read those papers, when they speak with me, and when we share even one case together, then I typically have found a new provider who is then saying, can you find me somebody like you near where I live? Mm-hmm. And to me, that's a win. That's a win every single time.
Yeah, and that makes all the difference. And, just thinking back to your explanation of some of what vision is, talking about fixation and saccades and vergence and things like that, a common theme that I talk about is that, in medicine, when we don't know what to do with a patient, we kind of send them down 2 pathways. We either allude that they're malingering and maybe faking it, because how can I, Dr. Schwartz, not diagnose everything that's in front of me? And that's with sarcasm at 10 out of 10. And then, or we refer them to psych, alluding that they're crazy. And that's kind of where this injury has shifted along the last century, and especially the last 20, definitely 10, and especially the last 5 years. The explosion of data and research and conversation moving this injury forward from a rehabilitative standpoint has just, it's like a fire hose. So much of what your specialty is in neuro-optometry and vision and eyes and ocular motor control and things like that really focus on function and someone's ability to navigate through their world. So whether their world be, or their functional environment, I should say, be in the home or school or at work or in their hobby, or whatever it is that their environment is, that they're finding joy, or their professional place, whether it be a school for students or working on a line or a truck driver for an adult. So much of that, our patients don't have the subjective language to express the what and how they feel, which for me, and especially with brain injury and concussion, this is why a trained provider in concussion and brain injury is so important to connect with and to for someone's post-concussion injury or brain injury, whether it be acquired or traumatic. So, really, so I hope our listeners are really connecting to and listening to the words that you're providing, because quite frankly, you guys, neuro-optometry, really do such a wonder for our patients in terms of return to life and function.
Oh, thank you for that. We certainly all try very hard. And there are a couple of other points I do want to make about the interventions that neuro-optometry provides. We tend to be very goal-oriented. For example, just because I have somebody who has deficits of saccades, they have difficulty tracking. If they never really read a lot, and they really don't have a desire to read a lot, and they always use their finger to track, I'm not going to really waste their brain power and my time and their time training them to track really well. You know, my big thing is, you know, let's go with what you used to do that you would like to do again, because I can make you do what you did before, or at least get you better at it. But I may not be able to get you to do something that you've never done in your entire life. You know? And I remind people of that all the time and let them know that these are not exercises that are building your eye muscles either. This is all about neuromotor control, which, you know, you alluded to before when you said oculomotor control. Everything we're doing in terms of vision and in terms of, quite frankly, many aspects of deficits following concussion, not all, but many of them, it's about regaining neuromotor control, neurosensory control. You know?
And we speak the same language, me as a physical therapist and you as a neuro-optometrist. We really speak, and all of us do. And I realized that during my own recovery, you know, from neuropsychology to speech language pathology, OT, PT, you know, we're literally all speaking in short-term and long-term goals, functional goals, and, you know, how we interact with our environment. So it really is a beautiful thing once we can facilitate that interdisciplinary conversation across the aisle of, hey, here's what I can do as a physio, here's what I'm learning from Dr. Kapoor, what she can do as a neuro-optometrist, and here's how we can treat our mutual patient together, not mine, not yours. And it really, the patients benefit beautifully from this. So as we lead folks into episode 2 here, Dr. Kapoor, I would love to hear what's the best way to reach out to you to say hello and howdy, and, you know, any Twitter handles or anything like that you find helpful.
Well, in terms of my Twitter handle, see, you're really killing me here, Jessica.
I've got
know
it.
that I'm a novice at this. You're killing me here. So the whole group can laugh as I try to remember my Twitter handle. How sad is that, huh?
I have it here on the
At
Google Doc for you.
Neuro-iDoc.
Yep. So Dr. Kapoor's Twitter handle is neuro_iDoc. Yes, she is a brand new Twitter user, but she's doing wonderful with it and handling that new stress well. So it's neuro_iDoc, EYEDOC. And I'll put that link for you guys. And I'll also link up where she can be found at NYU, and also some of her book chapters and articles that we've spoken about in this podcast as well. So Dr. Kapoor, thank you so much for coming on to the Concussion Corner podcast. And we're going to go right in and record episode 2 here so we can get into some more detail of your work and some common themes from throughout your career.
That sounds great. Thank you so much for everything. This is so much fun and so interesting.
Thanks, Dr. Kapoor. I'll talk to you soon.
Okay.
Thank you for listening to the Concussion Corner, hosted by Dr. Jessica Schwartz. The information in this podcast is for entertainment purposes only and not to be used as personal medical advice. Don't forget to follow us on social media on Facebook, Instagram, Twitter, and YouTube at Concussion Corner.